Good afternoon to everybody. Thank you to be here. We start with the session where we dive in the future with the next generation of balloon-expandable transcatheter valve. I'm Francesco Bedogni from Italy. We have with me this is a great panel of discussants. We have the panel. Eric Van Bella, Felix Mahmoud, Ole de Becker, Fausto Ferres, Manik Chopra, Theoman Kilic, Robert Van Guens, Andreas Holzhammer, and with me as co-chairman, I have the pleasure to introduce Andreas Bambach. So we will have three presentations where we try to examine the disadvantage, the feature of Myval Octacor new valve, and then we have a great live case from Toulouse. So I will go directly to the first presentation. Theoman Kilic will present us the first topic that is aligned for the future of Myval Octacor THV.
Whilst we set this up, may I just add that we're interactive, so if you're on the app, you can ask the questions and they'll pop up here. We'll attempt to answer them all in time.
Okay.
Over to you.
First of all, thank you very much for the organizing committee for the kind invitation. Today we will talk about Align for the Future with Myval Octacor. These are my disclosures. All we know that Myval transcatheter half valve series and Myval Octacor is currently used widely in worldwide. And among new generation TAVI devices, novel generation Myval transcatheter half valve series may have several advantages, also Octacor. First, the availability of intermediate and extra large sizes may allow the operator to fit the prosthesis to the patient without concern for over and under expansion. Second, the valve is directly mounted on a balloon-like stand and can be inserted into the introducer sheath. This delivery and implant feature makes the procedure more simpler and safer. Third, the valve can be retrieved through the introducer sheath and can be reinserted and reimplanted. If it is not being possible to cross the calcified aortic valve, for example, the sheath design permits complete retrieval of the valve from the patient and reinsertion of the same valve. Fourth, all sizes of valve can be used to have 14 French Phaeton sheath. And fifth, extra large size of advantage can be used in a extra large tricuspid and bicuspid anatomies. So these all properties cause that the use of new Octacor in bicuspid aortic anatomy, pure aortic regurgitation, valve-in-valve interventions, extra large aortic valve, mitral valve-in-valve ring, and pulmonary valve replacements even without stent implantation. When we look at the scaffold architecture of the Myval Octacor, it incorporates of two rows of tessellating geometrically identical octagons stacked one above the other, forming the inflow and the outflow zone. And each row is an interesting play of interlaced octagons, naturally incorporating a rhombus body at each intersection. You can see the two hybrid interlacing octagonal cell design. So one of the most important features of the new Octacor is its reduced foreshortening. So it creates a very good operator control, predictability of transcatheter hardware deployment. Myval Octacor frame foreshortens 19 to 20%, which made the best in the class. As you know, lower is the better. So when we deep dive to the properties of the Octacor, the higher external pulse skirt to plug microchannels may further reduce paravalvular leaks, and can be used in asymmetric cusp geometry like bicuspid aortic valves, cusp with severe calcium, horizontal aorta, and also intermediate size are very, very important. And there is a new landing zone marker on navigator inception transcatheter heart valve, so balloon for prerequisite positioning. This is also very, very important and safe for the operator. We know that precision sizing during TAVI is most critical one. Ideally, TAVI sizing has been in the range of 10 to 15% over the CT derives annulus diameter. So traditionally, balloon expandable size, valve size have been 2 to 29 diameters. So this limited size matrix necessitates adjustments in nominal volume in order to over and under expand to ensure a proper fit of the prosthetic valve to the patient's area-derived annulus diameter and to prevent any procedural trauma to the aortic complex. But this empirical adjustment to fit the patient to prosthesis is unnecessary and subideal and may lead to change in implant design geometry or lead to procedural trauma, especially in severe calcifications. So Myval Octacor size matrix has been developed to address this important unmet clinical need. The availability of the intermediate size valves could mitigate the hazardous selection of grossly undersized or oversized valve, thereby reducing paravalvular leaks, conduction disturbances, as well as life-threatening annular rupture. You can see the size matrix to 20 to 32 millimeter diameters with an area of 800 or 1 millimeter square. So this is very, very important. Even with the large annulus, you can use the 32 millimeter valve, and especially in pure aortic regurgitation even. So you can see the new navigator inception balloon expansion, and here you can see the radiopac marker. And the typical dog pattern of inflation steadies the transcatheter valve during expansion phase, ensure its precision, annular position, and deployment without any risk of valve migration. So rapid balloon inflation using a large volume inflation device is possible, and rapid balloon deflation also procedural safety and compliance. So new OctaAlign technique is an also important technique. The technique relies on the fact that the valve crimped extra with one of the Commissural posts aligned towards the mid-right coronary cusp or the left coronary cusp. And as per the patient's anatomy on multi-slice CT will automatically deploy as a mirror image in vivo towards the non-coronary cusp, the left cusp commissure or the right non-commissure with minimal misalignment. So during the advancement of the delivery system in the aorta up to the aortic annulus, the valve rotates almost 180 degrees and changing its orientation from anterior posterior to posterior anterior. And this will be also detailedly discussed today. So according to my opinion, new Octacor will be a revolutionist valve in the transcatheter valve area. Thank you very much for your attention.
Perfect on time. The rest.
We go on with Robert van Goens, who tells us about the existing clinical evidence up to the LANDMARK trial. As you all know, this is a prequel to tomorrow, where the LANDMARK randomized trial will be presented, and we'll have more deep dive into the data that come out of this. But what do we know as of today?
Yeah, thank you, Andrea. Thank you for inviting me and introducing me on this topic. So this is a Myval-sponsored session. I think you have all seen that for the moment. So we talk about the Myval THV series, and in the previous presentation you already have seen the specific designs of this valve. What I took home in the previous sessions, as in our previous experience, is you look at the lower left side of the graph, you see the traditional balloon expandables go up to 680 millimeters versus 840. What you can achieve is the largest Myval. And it was presented previously that in the Netherlands we have quite some tall people, so the Netherlands implant is 12% is extra large sizes currently. This is a slide where there's quite some already investigating trials, the Myval-initiated trials, and of course what we are waiting for tomorrow is the LANDMARK randomized trials. But I wanted to go over some of the experience where you could base on, are you ready for a randomized trial? And you want to know that from the device you're going to use. So there are 4 series, which maybe I want to discuss today. This is one comparing the Myval THV versus the SAPIEN 3, SAPIEN XT. It's done by the group from Ireland. And where you can see if you do a quantitative measurement of the aortic regurgitation based on video densitometry, and they used 740 patients to estimate the amount of aortic regurgitation. And if you see the regurgitation as measured in the LVOT, the more to the left, so that's the 0% regurgitation, and the more to the left, the more patients you have below 16-17%, the better your results are. That's based on the LVOT measurements. If you look at the echo, if you look around just more visual interpretation between moderate and severe, mild, and none of trace AR, you can see the experience of the Myval as very large patients having either none or trace or mild regurgitation, and only 2.8%, which is one of the lowest number of patients having moderate to severe. If you look at another way to look at the quantitative measurements, compared to the Sapien, you can again see the quantitative regurgitation 6.3% being very low. Now we have the eValve registry, which is a bit smaller, 366 patients which were analyzed, but they have more different kind of endpoints. They have a primary endpoint comparable to the LANDMARK trial with the FARC3 criteria, and you can see that the Myval was reaching 95% after implant, reaching a successful implantation and no complications. Now, if you again look at the paravalvular leakage, and if you compare that from 30 days, but also 6 months follow-up on the Myval versus an Evolut in this case, you can see the significant difference between a balloon-expandable and self-expandable stent. And there's also, everyone in the room almost here would know that the incidence of permanent pacemaker implantation of balloon-expandable TAVRs are very low. Now, published last year, over 22, there was the 2-year follow-up, and this is the Myval. If you compare that, there's no difference between in the regurgitation from 30 days to 2 years. No, also we have realized the 32 millimeters Myval having a very large annulus you could treat, and this is a small study, it's only 10 patients, but what was interesting, if you look at the annular area, 712 to 822 square millimeters were implanted without significant complications, mild PVL in 3 patients, vascular complications in 2 patients. So there's quite some evidence to go for the RCT, and that is what I wanted to discuss with you, the LANDMARK trial, which is a prospective, randomized, multinational, multi-center, an open-label, non-inferiority trial on 768 patients with the TAVI via the transfemoral approach. It's either a randomization between the Myval THV series or contemporary THV, which could be either a Sapien or an Evolut series. It is kind of double randomization, and interesting to see the differences between the two of that. There's a lot of follow-up. There's a follow-up at 30 days, which is the primary endpoint, the FARC primary endpoint at 30 days, and then there's follow-up up to 10 years, looking all the different kind of endpoints, and you can see the strong scientific. One of the one is done to the left to me, and there are some other well-known names in here, but it guarantees the scientific quality, I would say, of this study. It includes a DSMB, it includes an independent clinical event committee, several core labs for echo measurements and ECG analysis. The primary combined safety endpoint of the LANDMARK trials at 30 days, you can read as all-cause mortality, all-stroke, bleeding, acute kidney injury, major vascular complications, and then the moderate to severe prostatic valve regurgitation. There's a pretty good chance that that will be a major driver, I would say, and conduction system disturbances resulting in new permanent pacemaker implantation. So these over 700 patients are mainly recruited in Europe, and the top includers are from the Netherlands, and our center with Niels van Rooyen included 110 patients in this trial, and that's why we are so eager to get all the results shared with you tomorrow. In principle, the LANDMARK, again, it's a randomized head-to-head comparison in the TAVI device trial, comparing the Myval with contemporary standard THV patients in severe aortic stenosis, and they are presented tomorrow morning. So the essentials to remember from my presentation, if you want to remember anything, it's the wide range of sizes, the intermediate sizes, the XL sizes in the Myval, the expanding clinical data, and the RCT coming up tomorrow morning. Thank you for your attention.
Thank you, Robert. There's a great presentation. So we have so many interesting data about the registries of the result of Myval compared to the other current devices, but it's important to see tomorrow the late breaking trial where the landmark trial is presented. So don't forget to come to see the presentation of Patrick Serlus about the results of a landmark trial. So next presentation is done by Andreas Holzhammer, and that's OctaAlign intuitive, reproducible, and commissural alignment technique. This is a feature, a particular feature of this valve compared to other balloon-expandable valve that we can do a correct commissural alignment. Andreas.
Hello. Thanks for inviting me to speak about this topic here. Commissural alignment. I think we didn't care too much about it in the last decade, and obviously we learn from year to year more factors why we have to do this. And actually I think nowadays we tending to go to younger patients, there's no more question that there's a need to implant, especially the index valve, commissurally aligned due to various reasons. The most obvious is coronary access. Without any question, you could argument in a low stent height valve like the Octacor, that's not too important. But you should always keep in mind that this might not be the last treatment for that patient, and that you have no more option to do any modification of the leaflets if you implant in a bad rotation, that first device. Other arguments also interesting are less PVL, at least shown in some devices. Better sinus washout, meaning less, and that was proven clinically, not only in bench testing. So less halt in patients with commissural aligned implantation, which for sure will lead to a longer valve durability. Less central leakage. The closing of a native aortic valve is not by the diastolic blood pressure, but by the turbulence in the sinus. So all these factors are, I think, out of question nowadays, that we have to aim for commissurally aligned implantations, which was one of the downsides of the balloon-expandable valves, and now we're starting to learn how to do this. So the OctaAlign approach is a technique proposed by Myval, which is mainly based on preoperative planning. Means you assess the CT of the patient in a certain way, I'll show this later, and crimp the valve in an orientated fashion. And the assumption is that when you advance the valve through the aortic arch from a femoral implantation, that the valve basically flips over 180 degrees. This is a simulation trying to show this somehow, but it's important to keep in mind for the later part. Basically, from our viewpoint, being the implanter, the valve flips. Of course, it does not bend in the catheter, but this is due to the aortic arch. So the pre-procedural planning is quite easy because we do CT in our patients anyway, and we need to go to the three-cusp view in the mid-sinus plane, so a bit higher than we would do the annular measurements. And we basically start looking where do we want to have the posterior post, meaning where the yellow dot is here, obviously in most cases, patients close to the commissure, between the left and the non-coronary cusp. In the next step, we just draw a line, here indicated by the arrow, between that post and the center line of the device, ending up in the middle of the right coronary cusp in regular anatomy. And then we superimpose in the CT scan this clock. And I have to admit, initially I didn't really understand why we use a clock here, but don't go for the angle. But I think the obvious reason is whenever you use angles, you can mix it up in positive, negative, what is meant positive, negative. So this clock here, this example here is just a couple of minutes before 3 o'clock. This clock here is has a definite meaning. Yeah, there is no left and right missing. So that is, I think, the reason why this was done by this clock called angle. Other example here is straight 3 o'clock, and this here is 3:05. Hope this is kind of obvious. If not, I think you will have the chance also to get this explained in detail in the training village of the company. In the next step, that angle is transferred in the crimping process, and there is now one of the features of the device really helpful, and that is that on the crocodile crimping system, that you have this dial here of the clock, and this is used to align the post of the valve prior to crimping, And then the delivery system is inserted in a straight way, meaning the upward part facing the ceiling of the room to have the reference. And the valve is crimped in that predetermined way. Then the implantation goes on. And here, of course, it's key to insert the system without any rotations. And therefore, on the newer generations of the delivery system, there's a marker on it that you can just monitor, and that makes it quite obvious when you unintentionally somehow rotate the system while advancing, which of course would make the whole pre-planning of your crimping of the valve somehow ridiculous. So the device is advanced, and that is basically everything the operator has to do. So something which is, I think, really easy. You implant the valve in a normal fashion, and afterwards you can assess this alignment. I mean, the easiest way for sure is to do this by CT scan. There's a couple of publications to that topic. That's not unique to Myval, of course. But normally the reference is the right coronary artery, and you measure the angle from the right coronary artery to the commissures pre and post TAVR. And then you find how far you are misaligned. Another good technique, I think, sometimes you don't want to go for a CT scan afterwards due to concerns of kidney function, X-ray exposure, and also patients' hospitalization flow. Another way is to assess this in fluoroscopy. You can clearly see the posts in the Octacor device, and by measuring the relative difference between the radius of the fully expanded valve and the way from the middle post to the central post, you can easily calculate that. That is also a published technique which is straightforward. Looks a bit more complicated. Actually, I think it's 9th grade school math or so. Should be feasible. Okay, so how to do this in bicuspid? I mean, or other anatomy. Sometimes, you know, this is some coronary anomalies or just not origin of the coronaries in the middle of the sinus. So this whole thing should be adjusted if you want to have the focus on coronary reaccess at least. And there, the technique is also usable, and you basically position, I would do it this way, is to position a virtual valve with just 120 degrees, like the device is designed, of course, and to rotate it until you find a suitable view. And then you just take the posterior post and do the same thing. Draw that line through the center line, then get the clock angle and transfer this to your crimping. There is some data only available about the efficacy of that approach. There's a series of 32 patients which were assessed by CT post-TAVR. And what you can see here is that 12% had still severe misalignment. But in comparison to a random distribution, which we know that do we have in balloon-expandable valves, otherwise, I mean, you can, by this simple approach, at least halve the number of severely misaligned patients. That is, I think, the takeout from what we have so far on analysis. There's also ongoing research, which is kind of interesting, where you simulate the whole path of the valve through the aorta. That here was published by Ignacio Santos from Spain. And they did both bench testing in models and also in patients in this publication. And there the whole path of the valve is tracked, because we must never forget this approach is an assumption that the valve is flipping 180 degrees in a straight plane. And reality is, of course, tortuosity of the aorta that can be addressed only by doing a more proper or a more detailed assessment. So to conclude, it's an easy technique. Basically, for the operator, there's absolutely no learning curve. The valve is crimped to the operator, and the only thing is to mix it up is to turn the catheter while advancing, but that shouldn't be done anyway. There's a dedicated device available, both the crimper and the catheter, which is, I think, something we have to appreciate a lot, because it also gives us room to develop further techniques for other access sites and also for other centerline-based approaches of this alignment. There's no special hardware besides the delivery system, of course, or software necessary. And another aspect of these conventional aligned implantations, which is quite good here, is that it is absolutely safe. It does not add any risk to the procedure. We don't torque or rotate the catheter within the calcified anatomy, which might cause, or will cause for sure, some debris that we mobilize. The operators are not distracted because there are no extra steps, no changes of angulations or anything like that. We don't even add X-ray to the whole procedure, X-ray exposure or contrast. But there might be future advancements of this technique to even get better results by, I think, tracking the center line will be one of the approaches. Thanks.
Thank you, Sandra. We are perfect on time. So, well, probably if you have some question, you can address here, but probably we will answer at the end of the procedure.
So at the moment, I don't have any questions from you. Again, you can use the app or just simply get up and come to the microphone. For those standing, there are seats up front. You can take those. We promise we won't ask any questions. So maybe, I mean, do we have time for some questions to discuss what we've just heard?
So just one question. What is the advantage of the octagonal shape compared to the other current THV that has a rhomboid, if you want to answer, Tillman or Andreas, for maybe what's the, okay.
Most important advantage is the two-row and the foreshortening. The foreshortening is very, very important during deployments, and it's the lowest, maybe the foreshortening, so it's very operator safely.
There is some calculation about the foreshortening. Yeah, we have some bench test.
It's less than 20, yeah. Maybe a question for Robert van Geuns. How important is the intermediate size in true practice? Because I know you use the system in clinical practice, not only in the study. So you must have a feel for the change of how you do sizing for everyday patients. Right?
Yeah, as I mentioned, we have 12% large size, so in the Netherlands, and then we look at the other sizes in that, and intermediate sizes, and in between. So we are currently depending a bit on the calcium. So if you see a very high calcium load in the valve, a high calcium load in the outflow tract, close to either the sinotabulary junction, you don't want to overstretch too much. Otherwise, that will be a lower 5%. If there's not so much calcium, you want to have good grip, then we more aim at the 10%, based on the tables you have on the amount of milliliters of volume you put in the balloon.
So there is a question for Andreas.
Andreas, one question. You mentioned that you were checking in some patients commissural alignment with the CT post-procedure. Can you explain us a little more when you were doing it and what the added value clinically is? I mean, academically, for sure, it's interesting to assess whether you have done it properly or not. But clinically, what's the value of doing another CT in your patients?
I think there was kind of a misunderstanding. We don't do it in routine. Sometimes you have reasons to do a CT scan anyway.
And then you check.
But we are also struggling in each study where we have by protocol post-op CT assessment due to ethic concerns. So I don't do it routinely, and I think that it is absolutely feasible to see the alignment in fluoroscopy only. So no need for that. It is always considered the gold standard, but honestly, when doing this assessment in the CT, it also has some room for errors, I think. I would not recommend to do this in cases just for fun.
Maybe one small question to Robert van Geuns. He showed on the large sizes he did, I think it was 12 cases or something, that you did a predil in 9. Is that your standard way of doing it? You do a little bit more predilatation when using Myval or not?
I think that's from the Netherlands. So we have to be careful. We didn't do all cases in Nijmegen, all cases from the Netherlands, although we have randomized 100 patients. Predilatation is less standard, I would say. So we will discuss, or you will discuss it during the preparation of the next case. That's a very high amount of calcium and a very small remaining area. So I think we are less than 50% of predilatation in our center.
Okay, thank you. We have to proceed to the the live case from Toulouse. So Andreas Baumbach will present the patient.
So that was the perfect segue. If I could have the slides up, I've got them here. Right, to the case. So now let's focus on this patient that will be treated with the system that we've just discussed, but now it's about the patient. Mr. NF in Toulouse is 87 years old. He's been admitted with decompensated heart failure. So that's not everyday practice that somebody is brought forward for treatment in this state. He's got chronic kidney disease, he's got permanent AF, he's got known aortic stenosis, but he just was lost to follow-up, which happens to all of us. He's got hypertension. He's in New York Heart Association 3 at present. He weighs 72 kilos and is not as tall as the people in the Netherlands. He's sedentary and independent at home. He's on a large dose of furosemide at present. He's on apixaban, lisinopril, pantoprazole, dapagliflozin. Now, the lab is interesting, particularly the NT-proBNP is 19,000, so I think we can assume he's in heart failure, and the renal function is impaired. Now, transthoracic echocardiogram, the left ventricular ejection fraction is 25%. He's got severe, I would call that critical aortic stenosis with 0.47 square centimeters area, a mean gradient of 41, and still a Vmax of 4 meters per second despite the impaired ejection fraction, moderate MR, moderate TR, and a pulmonary pressure of 54. He doesn't seem to have a coronary disease, although we'll see some calcium on the CT later. So that's the summary. 87, NIHA 3, severe AS, and severe LV dysfunction. And he's got an STS score of 9 and a Euro score of 14%. And we move over to the imaging analysis before we do the heart team discussion. But you can make up your mind what you would do with this patient now.
So Manik Chopra will present the CT scan of this patient. As you see, a very sick patient with EF, a very low EF, and despite that, a very severe mean gradient with comorbidities. Is a really sick patient.
Thank you, Francesco. Thank you, Francesco. Thank you, Francesco, and good afternoon, all. I'm going to walk you through the CT scan analysis of this patient. These are my conflict of interest. Beginning with the sequence available for analysis, we can see a double oblique view on the left-hand side, and we can see that the mitral valve is open, the LV is relaxed, meaning that this is a diastolic phase assessment, and we all know that the numbers which come from diastolic phase are going to be probably lesser than the systolic phase, and the sizing is mainly on the systolic phase. So by chance, if the sizing is borderline, we should know that the true numbers are probably slightly more than what we are going to get. Also, the LV is dilated more than what it should be in diastole, and we know the reasons. The right-hand image shows a tricuspid aortic valve, clearly a thickened and calcified leaflet, 3 commissures, 3 cusps. Trying to analyze the aortic root complex with 3D planar reconstruction with dedicated softwares. We start from the bottom, and then, so it's annulus and LVOT. Annulus is 563.5 millimeters square. LVOT is pretty much similar with 575 millimeters square. Regarding the sizing part, we know that Octacor is having sizes at 1.5 millimeters increments, and by adding 1 or 2 cc's or taking off 1 or 2 cc's, you can fine-tune the anatomy to almost 0.75 millimeter. So in this case, probably the valves to be considered would be 26, 27.5, and 29, and you can see probably 27.5 matches the native anatomy the best. Of course, you can add few cc's more or less to probably get some degree of oversizing or undersizing, depending upon the patient's anatomic features and the operative preferences. SOV is large, STJ is also roomy, 29.5, but you can see calcium on the upper left quadrant. So probably we'll have to be careful. We don't want to rub hardware there. Also at the same time, we will lean more towards 27.5 rather than 29 to prevent any interaction at this level. We also see some calcium extension into the LVOT, as discussed earlier. If you respect anatomy well, probably we want to match it, and that's why probably Octacor intermediate size would be better. Membrane septum is 4.1 millimeters. The typical deployment would be around 2 to 3 millimeters below the level of annulus, and then probably the interaction with the conduction system is going to be quite less. LCA and RCA height appears to be good, although the arteries are calcified, they are probably not obstructive. You can see on simulation of Octacor 27.5, RCA is way above the level of transcatheter heart valve as well as above the level of the native commissures. The left also appears good, but if you want to go further, you can probably calculate the distance in between the simulated valve frame and the aortic complex, both of which at the lower LCA level and probably at the top of the commissures of the native leaflets, both more than 4 probably makes us more safe. Regarding the OctaAlign, beginning with the mid RCC, it would be probably 259 clock angle. Clock angle for mid RCA would be 255. And probably if you focus on the right-hand side of the screen, you can go for patient-specific commissural alignment, in which probably you would calculate the angles in between the RCA and LCA, which comes out to be 146. We know that the commissures are oriented at 120 degrees. And we also know that the RCA is way high. So you can probably just align to LCA, and the angle which you get is probably 259 again. These are the 3 views which you get from the S-curve. This is the 3-cusp view, which is basically for the valve deployment typically, RL cusp overlap view to assess the depth as well as to assess the commissural alignment. And then you have LCC side view, meaning NR cusp overlap view, which would tell you about the left coronary and its relation with the transcatheter heart valve. Also, the same view can also give you insight about the RCA. Now, the leaflets are super calcified. They are uniformly calcified, will lean more towards predilatation. And on the right-hand side image, you can clearly see it's sort of a porcelain aorta, and you can see all the 3 cusps calcified. You don't need to inject to put a pigtail in. And coming to the next one, the left-hand image clearly shows a completely calcified aortic arc. And from the point of the puncture up to the aortic valve, it's a completely calcified system. So we have to be careful with the hardware, navigation of the hardware. The femoral veins are all good up to the right atrium, so good for putting a temporary pacemaker if they want to. And regarding the peripheral arterial assessment, the image on the right-hand side, both the common femoral arteries are completely calcified. However, there is a sweet spot for puncture on the top of the right femoral head, just below the inferior epigastric artery, which is entirely calcium-free. You do not have such good spot on the left-hand side for the index TAVI insertion. All the numbers above this level are good, except for just below the aortic bifurcation, where it is probably around 7.4 near circumferential. So you may expect some resistance or friction here. So it's important to know regarding the puncture point and probably higher up, so that you can plan the procedural strategy and also the bailout strategy if something goes wrong. Coming to the carotid assessment for cerebral protection, we know that it's a regular arc, and to separate all these 3, it is best to go in LAO 30, and you'll be able to separate them well. It's all good for cerebral protection. So the anticipated challenges would be annulus to LVOT calcium, calcified STJ, completely calcified access path from the puncture point up to the aortic valve, borderline common iliac artery on the right side, and challenging puncture points on both the sides, right being more difficult than the left, apart from the clinical challenges with the patients having. Thank you.
Not only clinical complex case, but even there is anatomic complex case, because a very calcified aorta, porcelain aorta, LVOT calcification. So I asked you to discuss something. We have 5 minutes for the our team discussion. You know, it's like a partner A patient. You know.
Yeah. So Francesco, thank you very much for giving me the word. So this is the most important point in the history. An 87 years old man with a severe heart failure, taking more than 100 milligrams of diuretics, with more than 19,000 BNP, he is independent at home. We need to check this point. 87 years old with a severe clinical situation, the patient cannot have dementia. He may not have be dependent
Fausto, I think
be treated.
we discussed that with the team. And it says independent. He actually was quite good. He was lost to follow up, but he's got everything to gain.
I think it's very important.
They made a hard team decision there to say this is absolutely a patient that needs treatment and should be treated.
Yeah, that's what I would point. So the second point, the patient has a severe ejection fraction depressed, like 20%, but it still has some gradient. There's some reserve in the function. So with the aortic valve at 0.4, needs to be treated. So that's no doubt about that. But it's so complicated, as Francisco said, with the severe calcified syncytial of the femoral arteries to the aorta to the coronary arteries. Fortunately, there is no disease in the coronary arteries, but we can treat it. And just finishing my talk, when you asked Andreas about the intermediate size, when you don't want to be the right and then on the left, be in the middle. So in this patient, I think 29 is too much and 26 is small. Maybe we can go to a 27.5 millimeter valve.
I think it might turn out to be a case that shows the benefits of having 1.5 millimeter increments. Because we really don't want to oversize in a situation like that, and we feel uncomfortable to undersize. We'll see what they do. But
always doing a predilatation in a case like this.
Predilation, yeah. Who would predilate this case? Who would go in with any device straight away without predilatation? Some, okay. I think the majority tends towards predilatation because it's a critical case, and you want to be sure that you can pass your device, any device, I think.
I think it's not about probably not about prolonging life in that individual, right? It's more about quality of life, right? Quality of life, and enable heart failure therapy in that individual as well. I mean, severely depressed, left ventricular ejection fraction, low blood pressure, probably. So you want to enable heart failure therapy, guideline recommended heart failure therapy, and that's also something we have to keep in mind, I guess, in these very sick individuals that we're exposed to all day.
Ole?
No, I think there's no doubt about the clinical indication, I would say, regardless of his age. I mean, this man needs treatment. And I think, anatomy-wise, I would say it's probably suitable for most of the devices we have on the shelf. Yeah.
Well, about the anatomical access, I was a little bit worried about the 360-degree calcification at the ostium of the iliac, common iliac artery, because probably we have 7 millimeters the internal diameter, but probably the calcification we may have some trouble to cross. But anyway, we have the Python sheets, so we can cross and see. Okay.
You want to show us what they have in mind? Francesco, you want to show us what they have in mind, the operator strategy?
Yeah. Yes, I think you have no.
The last
there
slide.
Is no, yeah, there is no slide, but what we have to highlight the key steps of the transcatheter with. Okay, this is okay. See, probably what they have in mind to start is a conscious sedation. They decide to do a brain protection because of the heavy calcification of the aortic arch, right femoral main access. They will prepare with a pre-closure with one proglide and one 8 phalangoseal. They predilate with a 22 balloon. I think I agree with everybody or in the Congress, and they plan to place an intermediate size Myval Octacor 27.5 at nominal volume. Didier? Hi Didier, could you hear us?
Hi guys.
Nicolai, okay.
Hi guys, we can't yet see. Now we can see you. Now you can wave again.
Okay.
Welcome.
Good afternoon. So welcome to Clinic Pasteur for this live case. The objective is to share with you how we're going to treat this high-risk patient. We heard all your comments and agree with most of them regarding the strategy. Maybe one small but important precision, of course. The question of futility of indication was asked for this patient, and for all of those patients, we get the help of geriatricians to try to be sure that we won't have those kind of future indications. So this patient, despite his hazardous features, is independent, has good quality of life that needs to be preserved by treating DAS. Having said that, Didier, I think we can directly dive into the procedure.
Yeah, it's a quite complex patient, but this is daily practice. It's all about sharing cases together to all learn together. So what is the setup of the patient? If you focus on the maybe bottom left part of the screen, you can see that we have a 6 French right radial access that is going to, that houses a sentinel device, cerebral protection device, and we're going to show you how we deployed that afterwards. Nicolas already has prepared the right common femoral artery with ultrasound guidance, guided puncture. Single proglide was deployed, and we're going to demonstrate at the end as we close the arterial site access. We have a 9 French that is sitting inside. We have done a predilation of the common iliac. We've heard your comment, and it's perfectly aligned with our target, our strategy today. We're going to show you the fluoro afterwards. And then on the left side, we have a 6 French sheath. Once again, ultrasound-guided puncture, housing a 5 French pigtail that is going to guide us for the deployment of the Octacor device. And everything is prepared for the left ventricular direct wire pacing. So maybe we can come back on the fluoro, Nico. Yeah. And this is what we have. Could you describe what we obtained?
Yeah, so these are the usual 2 projections, and the main ones we'll use throughout this procedure. This one is the right-left cusp overlap view. That is quite accurate as predicted by the CT scan, Didier, where we see a quite interesting repartition of a calcium load at the level of a valve. And this is the freecus view. We see the freecus view here. Also, I would say quite conventional one, only mild AR associated. Few words briefly to document the placement of a sentinel device with a conventional technique. And as you said, Didier, because of the access you've analyzed at the CT scan, we decided to predilate the right iliac artery. So this was 7 millimeter.
Yeah,
balloon.
7 by 60 millimeter balloon. That was able to expand quite nicely. So before we dive into action, I think it's pretty interesting to focus now on the sheath. So we're going to expand a little bit the video screen, and you're going to see the sheath that is here. And you see, this is the 14 French expandable Python sheath that is able to accommodate all valve sizes, whether it be the conventional sizing or the intermediate sizes or even the XL sizes. So it's really something that is extremely useful. One single sheath can accommodate all valve sizes. So it's expandable. And so far, we've dilated the sheath with a 14 French sheath. And once inside the common femoral artery, and the iliac tree, we're going to dilate furthermore with this 18 French dilator. So this is where we are. And I think now, Nico, we can move forward.
Yeah. So our routine practice for all the transcatheter valve is to insert the large bore delivery sheath with on short Lundequist wire for the support it provides. So this is what we're going to do right now.
So the idea of this short Lundequist is to avoid any trauma to the aortic arch, basically because we have a lot of calcium here, and we want to make sure that we prevent as much as possible the risk of stroke or any vascular damage. So here is the Python that is advancing, and Nico, you are reaching the point of least diameter. Was it?
No, it goes,
scratching?
No, a little. I feel a little bit, but it really goes smoothly.
Excellent.
So it's okay. I'm holding it firmly, Didier.
Yeah, so let me withdraw that. And what we're going to do is to suture the sheath after the... just to make sure that it doesn't move because it's extremely hydrophilic. Slippery. We like it, but it's a slippery sheath and we need to secure it. So what is your experience, Francesco, with this Python sheath? Because you have a more extensive experience with this technology.
I think a very interesting sheath. So there's something to probably ameliorate in terms of membrane, but I think it's a good sheath. You can delay it. For example, in this case, I saw that there a 360-degree calcification in the iliac artery. You prefer to predilate before. Eventually, you can through this sheath you can dilate inside the sheath if you have trouble to advance, because one of the advantages of this valve is that you can pull back the valve and then insert the balloon. But it might be something better in terms of membrane, but is a largely acceptable sheath. This is an important thing that you are doing now, so you have to.
Yeah. It's too advanced now, but 18 French dilator. But it's okay, huh? Here, of course, I'm feeling a little bit of resistance.
Okay.
But it's okay, Didier.
Some colleagues advocate to do this step for the larger valves only, but I think it takes a minute and it just takes away some of the friction.
Anyway, this is a passage you can't avoid because the risk is to move the valve through the balloon, and so it's better to predilate every time, because once we insert the valve without predilatation, so this is important.
So the Sentinel is in place. It's all about contemporary practice. So what we're going to do is to move more le guide droit, s'il te plaît, towards a near cusp overlap projection or the cusp overlap projection, just to try to identify the location, the opening of both the non-coronary and then the superimposed left and right coronary leaflet, because here it's extremely calcified. And I heard your comment about the amount of calcium that was visible, particularly in the non-coronary side, Nico. And that's why I like this type of projection, because we should be able to see the movement of that calcium both during the predil as well as the valve expansion. And it's quite important because it's all about avoiding damage to the aortic root with these intermediate sizes, because it's going to be a 27.5 Octacor device, as well as monitoring the movement of the calcium during this phase. Okay, so Nico, please.
There's a question from the audience, and that is, along with the Octacors compared to Myval, was there a change in the inflation device, in the inflation device as well, or in the whole system, or is it merely the valve that has changed?
So the inflation device has changed as well. You're gonna see that it's more ergonomic, easy to handle, and it's going to be a full volume expansion here. Whether we go for a gradual expansion, it will depend on the movement of the calcium and the way we anticipate any kind of complication. But it's everything has been refined, redesigned, more ergonomic and more intuitive in terms of user-friendly usage. Nico, maybe we can focus on the hemodynamics. It's very interesting because, guys, we can all discuss that. It's a very low ejection fraction, and here is the peak-to-peak gradient that we have.
Yeah, the patient, and it was also known from the echo, the patient has contractile reserve, and of course that was part of the drivers that led us to accept to treat this patient, hoping for improvement and recovery. For congestive heart failure standpoint, also we see that the LV and diastolic pressure is not too high, so he received a lot of diuretics, and it was said, so it was optimized before the procedure. So okay, I think that's all what we can comment, I think, about the hemodynamics. Not a large, quite a large difference between aortic diastolic and diastolic pressure related to a lack of severe AR so far.
So here the idea is going to pre-dilate, as we said, and we would like to get your experience, guys, Andreas, Francesco, and all the members of the panel about the type of balloon and the diameter of balloon that you would use for this particular patient. Would you go for a quite strong predil, aggressive predil, or something that is more gentle?
Personally, we just try to make the idea is that you afterwards don't have resistance for the valve, so a 20 or 22 will probably do. Eric, what do you do?
No, indeed, you are. Indeed, we do the same. We don't know exactly what we need to do, but basically the main reason here is to make sure that you have no problem to cross with the valve. Again, maybe one of the difference with the other system is that there is no blockade of the device on the balloon itself, so you have to be sure that the valve does not slip on the balloon. And indeed, it's why it's so important to pre-dilate the sheath first, and then to make sure that the crossing of the device through the valve is easy. So the balloon pre-dilatation is good for that.
So did you choose an 22 balloon, correct?
Exactly, a 22, and basically the rationale for us was exactly what was explained at the moment. Mainly as we have this accumulation of calcifications throughout all the vasculature and the arch, that will add some frictions, plus the tight aortic stenosis, to be sure that we will make the crossing easier once we will go with a valve. So we're in place, Didier.
Yeah.
We need, of course, routine practice for us is to place on the wire. So we have a balloon insulating the metallic wire. It's the time for us to test it. So let's try at 180, 180. And you see it's okay. So we have an effective pacing.
Yeah, it's
okay.
extremely, yeah. Okay, so it's accurate, so...
It's okay for you, Didier?
Yeah, so let's
pacing
go.
on. Okay, balloon up.
Watch the calcium, there is still that indentation.
Pacing off. Pacing off.
Allez, merci.
Okay, rhythm is here.
Yeah.
Pressure is recovering.
Okay, so let's withdraw the balloon. There is a bit of aortic regurgitation that could be related to the wire in place. And let's wait for the blood pressure to recover.
To recover a little bit, yeah.
So there's another question from the audience. If you have a second, whilst the blood pressure recovers, would you consider IVL for the aortic valve in view of the extensive calcium? I'm not sure we have that available really, but would you?
No, it's a project that is extensively studied by the industry. That leaflet modification preparation, whether it be ultrasound or whether it be dedicated balloons for that. It doesn't work for the time being, but that could be a way to explore in the future. There is another option, that is the ultrasound applied from the external part of the chest, targeting the leaflets, trying to soften the leaflet. It seems to work a bit. Whether it's sustained and durable, we don't know that yet. So I have one question that I would like to discuss with you guys. We are on time for the valve deployment. It's about that balloon valvuloplasty, Nico. Yeah. And you see the calcium. My concern is the calcium in the non-coronary side. Yeah. We can see that it still constrains the expansion of a 22 millimeter balloon.
Yes.
So it's reassuring. It tells us that first we shouldn't go for a bigger valve than a 27.5. And second, we have to pay attention to the way it expands during
exactly. Exactly. And I guess, Didier, you will pay attention to the resistance you will have while
feedback. You're right. Yeah. You're right, Nico.
Okay. So let's go for valve insertion.
So we're gonna show you the device, how it looks like first. So if you just we extend the view for the technical crew. If we start from the bottom, from the top, you can see that we have a quite well-defined tip. The valve is directly crimped onto the balloon, and we have dedicated deployment markers that are onto the balloon, within the balloon. So you're going to see that. We have the regular loader, and the overall profile is adapted to get across the Python sheath. The navigator system is very flexible. So most of the time, in the vast majority of the patients, you don't need to use the flex wheel. But at the same time, we have a bending, a flex capability, so it is steerable, so we can bend it, particularly if we are tackling an horizontal aorta. Yeah. Okay.
Your wire is a Safari small wire.
Exactly, Safari small, yeah.
So is it your regular choice, Francesco?
Yeah. Well, it depends. So it's a very small ventricle. We use extra small. everybody, but this is.
It's okay.
Yes. Yeah. Yes, Nico. So for the time being, let's see how you are tracking.
Yeah, I feel
Yeah,
it's okay.
okay.
We're going out.
So it's advancing extremely nicely. So the loader is out. Let's see how we
Very
go
easily.
again.
You cross very easily
Yeah,
after
exactly.
the dilatation, that's the iliac calcification.
Didier, just for the sake of the explanation, what we're going to do maybe is to cross the arch.
Yep.
And then make a pause without crossing the aortic valve to get some
explain the,
explanation, just in case once we are across the valve, we have to hurry to deploy.
Yeah, based on the condition of the
Okay.
patient. So we will cross first without steering, without flexing, and to see how it goes. So it's extremely
Okay, and let's make a pause here. Let's make a pause here, Didier, and maybe we can record without injection. Huh?
Yeah.
We can
n'injecte pas.
record this just for you to comment about the landmarks you see.
Okay, so here is the Casper lab projection that we're going to use.
It was largely
Okay.
easier
Yes.
that I suppose, but you both are very good, so there's no.
So you see the blood pressure. There is
Yeah.
still that significant amount of regurgitation. So to make it brief, you see both distal markers from the top and the bottom of the stent frame. What we also see are the inner markers that are really important. The flat one, the line that is the center of the balloon, and then we have the positioning marker that is the thicker one, and that is going to be placed at the level of the aortic annulus.
Yeah. Sorry, Didier, I just pulled slightly on the device because I guess we had maybe the nose cone just inside the valve, and we see the pressure that is coming down. So our anesthesiologist is working on that, and of course it's related also to the depressed LV function, and we know for this patient. So let's wait maybe to see if he can improve that.
Yeah, before we go for the
Before we
deployment,
go,
otherwise
and if
we will.
really he can't, and it's related to also the NAR that we've created, then we'll go for the deployment quite fast. Maybe we can make also an angio to see whether we have an AR. Okay.
Inject. Yeah, there is a massive AR.
So I think we should, because you say it's going in the, it's going. I think.
Okay.
So I think we should.
Don't wait
we should
for
go.
us, guys, and we'll talk through. You go.
Yeah. Okay. So it's a very important move, as Nicolas has done, to go slightly deeper and then to reposition by pulling the valve.
I think this is okay.
Yeah, it looks nice.
Let's record this one. Okay.
Let's,
okay.
Inject.
Go.
Inject. Okay. We go.
And now we go.
Ready,
Okay,
pace.
pacing on.
Listen. So let's pace. Vas-y.
Okay.
Okay. And what is really nice is the foreshortening. I'm looking at the calcium.
Okay. Deflate.
And pacing off.
And now you will need some support.
So what we not necessarily. Tu peux mettre à 70 s'il te plaît, Flo, la sim. So we're just going to pace a little bit more, but the blood pressure should be fine. Okay, 60. Let's pace at 60, just for the recovery.
Okay. Need time to recover, but that's.
Yeah.
This is a
So
demonstration.
just,
Always important to be quick and.
And just for the audience, if you wanna pace with the left right ventricular wire, direct wire repacing, you need an insulator. So you should pace with the wire in place and the delivery catheter in place as well.
A few comments we would like to summarize with you. We're going to come back now that everything is more stable on the deployment, but very educational, I think, to review a checklist you must have when you have to face this situation of hemodynamic crush. So we checked for aortic regurgitation, we checked for annulus rupture, we checked for tamponade, we checked for coronary artery occlusion, we checked for stiff wire interaction with the mitral valve. Of course, there was this conduction disturbance, but luckily there were no of those explanations. And it was, I think, basically made and explained by the very depressed and ill LV of this patient. So he needed a little bit of support just after the deployment and the transient low flow and no flow. Now I think you have the hemodynamic situation under your eyes. This is the final angio.
Maybe we can repeat it
Exactly.
now.
And we're going to repeat, but Didier, maybe if we have time, it's worth now taking time to comment on the positioning.
So let's get a step back. So if we step back, you see, as I said, the positioning marker that is the thickest one on the balloon has to be placed at the annulus or slightly above the annulus. And as you can see, what is really very important with that device is the minimal amount of foreshortening, like a couple of millimeters. So where you put the distal end of the stent frame is where you're going to land. So once again, the deployment. And at the same time, we had a look at the calcium, because on the non-coronary side, there is still that indentation, but overall, the expansion of the stent frame is appropriate. The patient, I think, now is not anymore dependent of the pacing system. It was really a transient thing. So he already had a left bundle branch block at baseline. He was an under atrial fibrillation plus a left bundle branch block. It's slightly wider, but not major. So what I propose, Nico, is that we repeat the angio now that the hemodynamic situation is better.
Let's do this. So
just to better understand about everything.
A few words also about the projection. This is our cusp overlap projection, right?
So, guys.
And yeah, please go ahead.
There was a question whether you could show a projection that confirms commissural alignment.
It's exactly this one. That was about to be my comment. We like to work in the cusp overlap projection for three purposes. The first one is to cross the valve, because it's contemporary practice. The second one is to see the movement of the calcium. You see it better in the cusp overlap projection, particularly for bicuspid aortic valves. And the third one is the commissural alignment. So the valve was loaded at 3 o'clock based on the anatomy of the patient. And here you can see, if you clearly focus on the posts, you can see that 2 of the posts are sitting on the posterior part of the anatomy. And one post is located just in front of the commissure between the left and the right coronary cusp. So it's a perfect alignment for this patient.
Yeah.
Okay, so this is where we are. Let us know what is the time left, and if we can go for the closure, or
I think you should show us what you have to show. We've got 13 minutes left on the clock, and we've done some discussion whilst you were away. So.
Excellent.
You were too quick.
No, it's okay.
So it was really a challenging patient, and given the level of the aortic blood pressure now, we can expect that the patient is really going to benefit from this.
But maybe coming to this, Didier, we're gonna, and I know how contradictory it is for our anesthesiologist colleague, but we're going to ask him to lower a little bit the blood pressure for the closure. Yeah.
So I think the patient is not dependent anymore, so I'm going to withdraw the pacing lead.
So just to make it clear for everyone, this blood pressure is unsupported, right? That's what the patient is doing without any drugs.
Exactly.
Yeah, exactly. Exactly, but we are around 220 of systolic blood pressure, so I would prefer to have a more physiologic.
So it was a challenging case. So I guess we were. It tells us about how prepared we have to be for every kind of single patient. So the anesthesiologist was there, and then I like the checklist that you proposed, Nico, because we really need to make sure that we understand the situation, and if there is some hemodynamic compromise, to swiftly understand where it's coming from and to react. Here we already had a clue based on the LV function at baseline, but we needed to check for everything. And was a little bit not worried, but a little bit cautious about the calcium, because you may also have a tamponade due to the puncture.
Exactly. That was, to be honest, while we were doing the angio, that was one of the things we were thinking about. But fortunately, it's not the case.
Okay.
What about the pressure now?
So it's slightly decreasing. We went from 120 to 180, so it's coming down. So, by the way, by the time you get ready, une éponge et des compresses, s'il te plaît. Yeah,
do you give protamine to this patient now?
It's a very important question, but I would say no, for two reasons. First, we had this hemodynamic issue. Second, the patient is in atrial fibrillation. And third, we still have the cerebral protection device that we need to withdraw. So for these reasons, we're not going to provide any protamine unless we have a major bleeding just right now.
So few words, Didier, about the closure strategy that is the routine one for us now. One per close prostyle was put before we start. You see that I had to tighten the knot, and then we advanced the 8-French angioceal and just assess the amount of residual bleeding around the angioceal. And here you see that we have some housing, but nothing really important. So it's a good signal for us. Yeah. So we're going to put the 8-French angioceal. In case we would have at that step severe residual bleeding, then it's still time for us to reintroduce the wire and go for either a second per close or for a plug device, for example, like a Manta, for example. But when we have this signal of not having an important amount of bleeding, then we go for this combination of ProGlide plus angioceal.
So that's a very important question, and maybe Andreas, Francesco, how often do you use the Manta device? Is it a regular closure device that you're using, or is it meant mainly for bailout procedures at your institutions?
In our experience is that we use very few Manta. We started with to use it, but we shift to double ProGlide.
Yeah, we're not using it.
Yes, but yes, we normally it's our is to use all the time a protective wire. Eventually to go back and close if we have trouble. But
yeah, and so this is the echo control we are doing. Okay, so the puncture was here just above the calcified plaque you see at the right side of the screen, and that were identified by the CT scan. So apparently no dissection, and we'll just check that now with a color Doppler. Easy. Okay, and you can reduce the.
Yeah, so there is a small narrowing, but you can see here.
Yeah.
About the flow, there is distal flow, but we can clearly see that there is a small narrowing. I like the echo because you see more about the presence of an intimal flap, the flow limitation, the location of the flow limitation, the movement of the calcium. And here it's calcified, but we have distal flow. The distal part, for those who are not familiar, is the right part of the screen, and it goes across that.
And these were the calcified lesions we had on the CT scan, so the puncture was done slightly above that to try to avoid those lesions.
OK. En régie, revenez configuration normale.
Nicolas, Didier, this is very interesting what you're showing now, because I don't think it's common use the echo test after the closure of the artery. We are used to control with the angio. I think the majority of us are used to control by the angio, but if you are experienced in echo, this is very, very important. It's very interesting
to comment on that, Francesco, the way it evolved for us through years is that we started with echo guidance for the initial puncture, and then started to try to control the outcome with echo also, with a kind of learning curve. So for a while we had a double assessment by angio and by echo to learn from that. And now routine practice for us is to do the echo check, the final check by echo. And in case we have some doubts regarding the flow, regarding the potential bleeding, in case the puncture was high, of course we always, or in obese patients for which the echo image quality is sometimes poor, then we always do a final angio control. But when by echo we have no doubts, we just have this final assessment.
So maybe I will take maybe 1 minute to summarize, because it was a very interesting and challenging case. So thank you for sharing it with us and helping us treat this patient the best way we could. We could demonstrate contemporary steps of a transfemoral THV in daily routine with this new device that comes with a different technology, these octagons, and that help us to really anticipate what is going to be the target depth of the device. And these intermediate sizes are quite useful, could be useful in daily practice. So we are looking forward to seeing the results of the LANDMARK trial. And I have to say that you did a master job, Nico, handling this patient, because it was really a complex patient. I would like to thank you for that.
Thank you.
And thank you, Laurent, for being with us. And also Florine and Benoit as well.
Dr. Richard, the anesthesiologist, to deserve applause also.
Nicolas
the floor is
and
yours.
Didier. What to say? Chapeau. Congratulations.
Great case. A bit of a roller coaster, though.
Thank you, guys.
Thank you, guys.
5 minutes more. People is leaving, so I think we can conclude that we had a great session, the great symposium. It's interesting presentation about the future of the Myval, a really great case, very teaching case, performed very, very well by a large experience center. Andreas, if you want to conclude.
Absolutely. Fascinating case, and I think a good prequel to tomorrow's LANDMARK. Thank you.
Thank you.